The title is Simplified Approach to the Imaging of Vascular Rings. That's abnormal development of the aortic arch and rarely the pulmonary artery may result in a vascular ring in which derivatives of the aortic arch, or rarely the pulmonary arteries, completely encircle the trachea and the esophagus, and hence the term vascular ring. Now, most of the anomalies that we're going to describe can all be derived from the classic Edwards double aortic arch, which Eric beautifully showed in his embryological study with the two aortic arches, each aortic arch giving rise to a carotid and a subclavian. And the most anomalies that we're going to describe are a result of abnormal patency of a vascular segment that should normally regress, or abnormal regression of a segment that should normally remain patent. Now, when the trachea and the esophagus are completely encircled, this may produce respiratory obstruction, and this is what we're going to focus today. We're not going to talk about incidental abnormalities that you may pick up. Now, most patients with vascular rings presenting with respiratory obstruction become symptomatic between 3 weeks and 2 years of age. And this is one series of 19 patients showing you the most common presentation in this series, around 4 months to 12 months. Unfortunately, as I said, ours are up to 2 years of age, and now I've just recently reviewed our 50 vascular rings that we've studied by MRI. This 1 to 5 year breakup, most of these present at a younger age. The symptoms of a vascular ring, as alluded to by Eric, are those of wheezing, a stridorous breathing exacerbated by crying, tachypnea, difficulty swallowing, and recurrent pulmonary infections. I believe that those patients suspected of having a vascular ring, that you begin with high-quality frontal and lateral chest radiographs and include a high kilovoltage frontal radiograph of the tracheobronchial tree utilizing the filter that Eric described, and we'll illustrate that in a minute. I think that one should pay careful attention to the aeration of the lungs, look at the tracheobronchial tree, particularly in this high kilovoltage filtered radiograph, identify the side of the aortic arch, the transverse arch, which is the portion that will deviate the trachea, and the descending aorta. Now, patients with normal aeration of the lungs and a normal tracheobronchial tree and a left aortic arch with a left descending aorta will rarely have a symptomatic vascular ring. If you can find a right aortic arch with either a right or left descending aorta, or a left aortic arch with a right descending aorta, or an abnormal tracheobronchial tree, that indicates a high likelihood of a symptomatic vascular ring, and those patients will require more definitive evaluation. And I believe that an esophagram should be performed as the initial evaluation of all these patients. Now, if the frontal and lateral chest radiographs are normal, your high kV film of the airway is normal, and your esophagram is normal, the universal sign is that of stop. I believe that nothing needs to be done. The patient is finished, etc. However, if symptoms persist, there's a few other causes that we're going to talk about. The innominate artery compression, and the one that Eric showed where the arch crosses over the trachea. If symptoms persist, I think bronchoscopy is next performed to evaluate for tracheal compression. And if your surgeon or whoever does your bronchoscopy recognizes a pulsatile impression upon the trachea, then I think you need to proceed. If bronchoscopy is normal, you stop. Now, patients with abnormal chest radiographs, airway films, esophagams, and or tracheal compression on bronchoscopy, you as the gatekeeper can now move to MRI. I believe that in 1992 that MRI is the procedure of choice for the definitive evaluation of vascular rings. I think it replaces angiography, replaces digital subtraction studies, and I believe, as I hope to show you, can even replace ultrafast CT. This is because of MRI's ability to image at extremely high resolution in all planes with large fields of view and no ionizing radiation. As described by Eric, our patients are scheduled electively, sedated if necessary in the manner outlined. I do a localizing sequence and then do cardiac-gated multi-section spin echo imaging in the coronal and axial planes, usually as 2 separate sequences of interleaved images at 3 or 5 millimeter intervals. Now, I believe that the interleaved images give you your best images. There is no skip, and even small gaps in which you may utilize can result in confusion. So I've now gone to interleaved images. It may result in a slightly longer examination. I think care is taken to image the entire thoracic aorta and the proximal great vessels in the coronal plane, and the aortic arch and proximal descending aorta and the proximal great vessels in the axial plane. You can do sagittal images if desired. I would urge you to correlate your MRI with your esophagram to arrive at a specific diagnosis. Let's move on and discuss common vascular rings. First, let's talk about a double aortic arch with both arches patent, as illustrated in this wonderful diagram from Klinkhammer, which unfortunately is no longer available in many libraries, but still can be obtained from your National Congress of Library. This is the old angiogram showing, as was illustrated by both Dr. Gooding and Dr. Effman, that the right arch is usually, we'll underline usually, the larger and more craniate or cephalad, if you will. The left arch is typically the smaller arch. Most patients present with respiratory infections, as illustrated here. On the regular chest film, it may be difficult to identify that the trachea is deviated to the left, identifying the right aortic arch. This is our high kilovoltage film of the airway, as we've described, and I think easily you can identify the right aortic arch displacing the trachea to the left. As was illustrated, the esophagram is performed in the frontal and lateral projection. Typically, the right-sided arch produces a larger impression than the left-sided arch. Here, little, if any, on the left side. There's always a retroesophageal impression. And this retroesophageal impression is seen with almost all vascular rings and does not serve to distinguish them from one another. It's the AP esophagram that may give you a clue. This patient underwent bronchoscopy. In my algorithm, you see that's not necessary with an abnormal esophagram, but this was done before that algorithm was derived. You are standing at the patient's head. You are looking down at the bronchoscope. This is anterior. This is the patient's left side. This is the patient's right side. In the proximal trachea, the lumen is widely patent. As we progress down toward the carina, we can see that the tracheal air column is narrowed from the right and posteriorly by a double arch. At the level of maximal compression, we see that the right arch is producing striking narrowing of the lumen, and Dr. Effman showed you how small differences in tracheal diameter or radius result in enormous differences in airflow. And here we're at the carina beyond the obstruction. And these strikingly pulsate if you ever have an opportunity to look at these. Well, MRI is the procedure of choice, as I mentioned. This illustrates the typical double aortic arch with both arches patent. These are interleaved coronal 3 millimeter images photographed in sequential fashion. Let's move through these a little bit slowly. For starters, the left ventricle gives rise to the aorta, which bifurcates into a right arch and a left arch. Each gives origin to a carotid artery. Here we can see the trachea passing between the two arches, and you can see it's narrowing. I don't believe that CT can show this to you any better, because I can show this to you now in the coronal and axial planes. Notice that the right arch, as is most common, is the larger of the two arches. As we follow it back, we can see the origin of the subclavians on both sides, and we can follow the right arch as it swings posteriorly to descend on the left side. In this patient, there is a double aortic arch, but both the right and left arches are equal in size, said to occur in a large series of approximately at 9% of occasion. The left ventricle gives rise to the aorta, which bifurcates into two arches. Here's your trachea. Notice that the right and left arches are of equal size. In this patient, who is only occasionally symptomatic with his respiratory infections, there is very little tracheal narrowing. The right and left arches join posteriorly to descend on the left side. Here in the axial projection, we can work our way up, but for sake of time, you can beautifully see that the right arch and the left arch completely encircle the trachea. Here's your innominate entering into the superior vena cava. So I think you can beautifully see the relationship and hence the term vascular ring. And and the tendency toward anterior and posterior arches as illustrated here. Uh-oh. Oh, no. Could you back me up on the right side here, please? I draw your attention to this case, which is very important for you to recognize, because while your surgeon may do a left thoracotomy in the great majority of cases, this would result in disaster in this patient. Notice on the esophagram that while the right arch is typically higher than the left, it's the left arch which is the larger of the two in this esophagram. Follow me through this MRI study. The aorta arises from the left ventricle, gives rise to our right carotid, splits into two arches. But as illustrated on the swallow, the right arch, as is atypical, is the smaller of the two arches. This patient needs a right thoracotomy and the vascular ring broken on the right side with preservation of the left arch. Here we see the right arch, left arch, the two joining to descend on the left side. Moving on to double aortic arch with left arch atresia. This is a less common form of a double aortic arch, but also a very large incidence of vascular rings are related to this entity. They've been subdivided as illustrated. You don't need to remember these. These are in many manuscripts and will be in the new edition of Cathy. But suffice it to say that the most common vascular rings that relate to double aortic arch with left arch atresia are related to atresia between the left carotid and the left subclavian, or distal to the left subclavian. And here we've illustrated a patient with atresia distal to the left subclavian. We have origin of the left denominant, a right carotid, a right subclavian. Then arising posteriorly is the remnant of the left arch, that being the aortic diverticulum, adductus cumaral, with the atretic left arch completing the vascular ring. These patients also have respiratory infections. Interestingly, Eric, we have noticed a very small percentage of patients that have had localized air trapping with this, but it is infrequent as you described, but we have had a few on expiration that had an element of air trapping. The high kilovoltage film in this patient beautifully illustrates the narrowing of the distal trachea and the displacement a little bit to the left by the right arch. The esophagram is identical to double aortic arch with both arches patent. The right arch impression is slightly higher than the left arch. They, as the last series, also have a large retroesophageal impression. The aorta arises from the ventricle, gives origin to the great vessel, a carotid. As we follow it, we do not, there's our trachea, but we don't see a left arch. There is no left arch in this patient. There is your pulmonary, your tracheal carina, right arch, right descending aorta, an expensive way to make the diagnosis of gastroesophageal reflux, but there's our right descending aorta. Well, this is the same pattern of branching. Here we can see the ductus diverticulum giving rise to left subclavian. This is the same pattern of branching that I'm going to describe to you next. Right aortic arch with aberrant left subclavian. Can we differentiate the two from MR? I'm not completely convinced that we can, but the esophagram will. In the right aortic arch with aberrant left subclavian, there should only be a right-sided impression in the frontal esophagram. As you recall, in this patient with a double aortic arch with left arch atresia, there were bilateral impressions. It was of interest in this patient that I thought that he had a double aortic arch because as I followed ascending aorta, descending aorta, ascending aorta, descending aortic arch into the arch, I thought that the left subclavian, as it originated posteriorly from the ductus diverticulum, was tethered anteriorly. And that together, plus the esophagram, which revealed the bilateral impression, led me to believe this patient had a double aortic arch. And this was confirmed at operation when the atretic segment was divided here. This is a common form of vascular ring, that of right aortic arch with aberrant left subclavian, arising from the aortic diverticulum posteriorly. Here's a pathological specimen, an unfortunate individual who did not survive the vascular ring from Dr. Bill Roberts of NIH. You were standing at the back of the patient looking anteriorly, seeing the remnant of the left arch the ductus diverticulum, the ligamentum, if you will, and the origin of the left subclavian artery, encirclement of the posterior esophagus. These patients have respiratory infections and all the symptomatology that we've described. The trachea is deviated to the left. There's a right descending aorta. The esophagram can be a little bit confusing until you recognize that actually the impression upon the esophagus here is that from the ductus diverticulum, the left subclavian coming across. The right aortic arch is making this impression. I would also suggest that this esophagram can be seen in patients with double aortic arches. But that's the way this patient presented, and I show it to you as it happened. This is the retroesophageal impression seen in all forms of vascular ring related to the abnormalities of the aorta. The MRI study, ascending aorta, carotid, right carotid, left carotid, trachea, origin, I believe this is the subclavian, trachea, right arch, a little bit of left subclavian, and the last image beautifully illustrating the ductus diverticulum or the ductus Kumral originating, the left subclavian originating from it. In the axial projection, similar findings. We can work our way up, ascending aorta, descending, and beautifully follow the tracheobronchial tree throughout. And again, we see the left subclavian originating from the remnant of the sixth arch, fourth arch posteriorly. Again, a similar pattern to double aortic arch with left arch atresia. It's the esophagram that may give you a clue. Eric beautifully set the stage for an uncommon form of vascular ring, that of the pulmonary sling or aberrant origin of the left pulmonary from the right. In so doing, it encircles the tracheobronchial tree and often narrows the right main stem bronchus and the trachea. Recall that up to about a third or half of these patients have complete cartilaginous rings, and while you can easily operatively fix this, these patients die a respiratory death related to uncorrectable problems of the tracheobronchial tree. This is an angiogram and a sitting up projection showing the origin of the left pulmonary from the right as it passes around the tracheobronchial tree to enter the left hilum. Patients typically present in the manner that Eric described. This is a neonate. This is called retention of fetal fluid, and it relates to any type of bronchial obstruction. On 221, we can see a shift of the cardiovascular and mediastinal structures to the left. Already there's a difference in the aeration. This is retained fetal fluid in the morning, some clearing by the afternoon. On 222, we can begin to recognize hyperinflation of the right lung, and by 227, rather striking hyperinflation with shift of the heart and mediastinum even more to the left side. Your tracheobronchial tree is beautifully illustrated on your high kilovoltage film. This child unfortunately had complete cartilaginous tracheal rings. I think you can get a hint of that with narrowing in this neonate in the distal trachea. As has already been described, the esophagram is characteristic in the great majority, but not all patients, when you can see the left pulmonary interposed between the trachea anteriorly and the esophagus posteriorly. But as has been described by us and others, the esophagram may not be normal. This is your dream case. On your lateral chest film, you can recognize the left pulmonary between the trachea and the esophagus. You don't even need an esophagram. But this is classic. However, this may not always be seen. I'd like to show you this patient, which is always the case. They present at the wrong time, at the wrong place perhaps, but this presented over the Christmas holidays with minimal staff, but had classic chest films that I illustrated. My colleague Bill Nixon made the diagnosis of aberrant left pulmonary artery, suggested the patient have an echocardiogram, and thought the case would be done. Unfortunately, the echocardiographer missed it, as he mistook the ductus remnant for the left pulmonary artery, and I was asked to do an esophagram. I assure you that this is one of many films in which the esophagram was completely normal. Despite all efforts, I could never identify a mass between the trachea and the esophagus. And we've now noticed this in about 15 to 20% of our patients. Well, we were completely convinced that this patient had an abnormality of the right bronchus because of the retained fetal fluid, and underwent a water-soluble tracheogram while the MR machine was being repaired over the Christmas holiday. It was down, as typically the case, and it showed striking abnormalities as illustrated with proximal right bronchial narrowing. The MR machine was back up, and I'm not sure if this projects too well, but we can see hyperinflation of the right lung. There's your ascending aorta, your descending aorta, your pulmonary artery, there's your trachea, and the aberrant origin of the left pulmonary artery from the right as it swings posteriorly. So this patient had an enormal esophagram. This case has been given to me by Dr. Asani. You can also see hyperinflation of the right lung. A little bit easier demonstration, at least to recognize for me, the origin of the left pulmonary as it arises from the right pulmonary as it passes behind the tracheobronchial tree and in front of the esophagus to enter the left hilum. In the frontal projection, we have 4 slides. I think there are 3 millimeter interleaved images by Dr. Asani. We're looking here at the inferior vena cava, the right atrium. There's your pulmonary artery. There's your right pulmonary artery. Moving posteriorly, we can identify the tracheobronchial tree, the left bronchus. We can see a little bit of the left pulmonary artery, and then on this image we can see the left pulmonary circling behind the tracheobronchial tree. Remember, we're moving anterior to posterior, and we can see that the left pulmonary rises and passes behind the tracheobronchial tree in the coronal plane. I propose to you that we have a wonderful visualization of the trachea and the tracheobronchial tree with MR. I'd like to move to less common vascular rings, that of a right aortic arch with left descending aorta and left aortic arch with right descending aorta. I'd like to correct a misprint in the handouts that I submitted to Dr. Gooding. I believe it's on page 434 and 435 for those of you that brought that small tome with you. But in the left aortic arch with right descending aorta, the tracheal displacement is to the right, not the left as described. And similarly, the right aortic arch with left descending aorta, or the circumflex aorta, the tracheal displacement is to the left. As these are both similar, I'll only describe one. But as you notice, in this patient with an aortic arch that is on the left side, there's a segment that passes behind the aorta with a right descending aorta. And when you have a right subclavian and a right ductus, that is one form of vascular ring. Its mirror image is that of a right aortic arch with left descending aorta, with the ductus remnant here, the left subclavian, another form of vascular ring. Many people would consider this a variant of a right aortic arch with left arch atresia. This also goes by the term of circumflex aortic arch. A chest film in such a patient with a right aortic arch, a retroesophageal segment, and left descending aorta shows multiple small areas of atelectatic change, perhaps some hyperinflation, and certainly parabronchial pulmonary disease. The high kilovoltage film beautifully demonstrates the right aortic arch, and I think you can even get a hint that it's passing behind the esophagus. Certainly you can't recognize whether it's passing in front or behind, but we can see it passing to the left side to descend on the left. Another patient with tracheal displacement to the left, but notice the left descending aorta. There must be a right aortic arch and a left descending aorta. You can get some impression that the trachea may be displaced anteriorly. The esophagram illustrates the retroesophageal component as the arch passes from cephalad right to caudad left, produces a retroesophageal impression. Let's read across. Origin from the left ventricle, ascending aorta. Ascending aorta giving rise to a carotid, pulmonary artery, aorta, aorta, tracheobronchial tree, passing here next to the right arch. Right arch, see some subclavian here, right arch. The next image, we can see the right arch passing behind the esophagus, tracheobronchial tree to descend on the left side, and origin of the left subclavian from this ductus diverticulum. Circumflex aortic arch, or perhaps easier for you to remember as right aortic arch or double aortic arch with left arch atresia. This is the axial projection of such a patient. We'll move through this quickly. Your aortic arch, your right subclavian, ascending aorta, descending aorta, ascending aorta, descending aorta, as it drops down to descend behind the tracheobronchial tree and give origin here to your left subclavian in this region here. So it swings behind to descend on the left side. Eric described briefly the innominate artery compression syndrome. For many years I didn't believe this existed until I was able to see it under bronchoscopy and now document the changes, as I will show you, by MR. As was noted in Eric's handout, this is not anomalous origin of the right innominate. In a small percentage of patients, the right innominate artery, as it passes anterior to the trachea, will compress it. These patients will have normal esophagams, usually normal chest films, but the abnormality will be recognized at bronchoscopy, and then you proceed to MR. This patient has normal chest films and clearly had respiratory stridor. The lateral chest film demonstrated some anterior compression upon the trachea, but you can see this in many normals. The esophagram, illustrated only for completeness, was normal. At bronchoscopy, the surgeon described complete collapse of the trachea by a pulsatile vessel passing obliquely approximately 1 to 2 centimeters above the carina. And for that reason, the patient went to MR. Let's take a look here at the MR in this patient. Ascending aorta, origin of the right innominate. Here comes your tracheobronchial tree. Here's your trachea here. Notice that we lose the trachea right here as the innominate passes anterior to it, and now we have beautiful visualization of the right and left main stem bronchus. So there's clearly some compression by the innominate artery in the coronal plane. Let's look in the axial plane. Level of the pulmonary artery, right bronchus, left bronchus. At the carina, moving up, ascending aorta, descending aorta, under surface of the aortic arch, tracheobronchial tree just above the carina, top surface of the aortic arch, trachea. Your 3 great vessels, your left subclavian, your left carotid, your right innominate, the innominate vein passing over the superior vena cava. The tracheobronchial tree is widely patent. But look at this image right here. The trachea is nearly completely obliterated as the right innominate passes anteriorly. This made me a believer. It corresponded beautifully with the findings of bronchoscopy. This was a second patient who had symptoms of respiratory obstruction, normal chest films, normal airway film, but at bronchoscopy, an anterior pulsatile impression upon the trachea. Here's the airway film. My colleague, who will remain unnamed, thought there might be an abnormality in the trachea here, and I was asked to perform a tracheogram on this as we got off the loop here, and this illustrates one of the errors, I think, in doing tracheograms. The tracheogram was normal in all projections. And yet the bronchoscopist described near complete narrowing of the trachea under direct visualization. Well, what's happening here? The positive pressure is distending the trachea, and I am missing the anterior compression. Be aware if you do tracheograms that the patient must completely be at rest and that you can't have your endotracheal tube down to here. This tracheogram was normal despite the presence of rather severe compression on bronchoscopy. At MR, the undersurface of the aortic arch, the trachea. Middle aortic arch, trachea, SVC. Top surface of the aortic arch, already showing some tracheal narrowing, and as the innominate swings anteriorly, complete obliteration of the trachea. In the sagittal projection, which we've now had a chance to do in several patients, you are looking from right to left, 3mm images. This is the origin of the right carotid as it comes from the aorta. This is the innominate vein. The innominate vein, the origin of the right innominate, there is the trachea there. And on this next image, I believe that you can see as the right innominate swings or originates from the aorta that there's rather severe compression of the tracheobronchial tree. I mean the trachea right here. In summary then, the suggested evaluation for vascular rings, as we've discussed, is that of chest radiographs, high kilovoltage airway films, an esophagram. If those are normal, we stop. If symptoms persist, we do a bronchoscopy to evaluate for tracheal compression. If that's normal, we stop. In patients who have abnormal findings, we move to MRI. As we conclude with a look from the tram at Snowbird, I'd like to thank Dr. Gooding for inviting me, and the hosts, Dr. Taby and Dr. Brash. I often wish when I stand here that I could quote wonderful philosophers, bring Greek into play like Dr. Gooding, or philosophers or writers as illustrated in the front of your manual, but that's just not me. I'm just not widely read, but I only remember one philosopher. In fact, it was a woman philosopher. Her name was Mae West.